the erector spinae muscles come down into that thoracolumbar junction. And we just don't want to put look at this, there's absolutely no rotation to the right up here. And the way that I can isolate that better is by doing this, which will probably irritate the tissue, and try to rotate in the last few days at the hospital. Where's your...
Walk around and see if you feel better.
Oh, yeah, that was a good one.
Hello everybody, this is Dr. Pearlman. Welcome back to the channel. And this is going to be another narration or narrative video that I am going to do some explaining about what I am doing and why we are doing it here at Paramount Chiropractic and Wellness in Richardson, Texas. And we had a few requests actually by students at Parker College, Parker Chiropractic College, who saw the last video and said, hey, you know, that was great. Can you make more of these? The explanation was really key in understanding why you're doing what you're doing and how it was effective. So what I'm going to do is get right into this. As you can see, we have our little promotional video here, our compilations, if you will. But I'd like to take this time to talk to you about a particular case where we're working with a young lady who has a left shoulder and left neck type pain. So her major complaint is the left shoulder and left neck, and it'll come up here in about 1 second where I'm adjusting her. And here we go. So I'm palpating and I'm feeling for restriction. And then what I say is that I'm going to adjust her T1. So that's the top bone of her back, actually, the upper thoracic and not the cervical. But we're going to do that in a seated, comfortable position where we're trying to actually lift T1 off of T2. There you go. And open it up on the left. And the reason we're doing that is because the brachial-plexus, as you can see, this is the brachial-plexus as it's called, and the nerves snake down through the shoulder blade, through the front of the scapula actually, some even in the back of the scapula, and they are tethered or tightened on this left side of hers, feeling tension. So we need to find a way to actually reduce the tension and reduce the tethering on that kind of forward head complex and upper neck area. So you can see how it refers from the neck down through the shoulder into the arms and the fingers. In this particular circumstance, focused on the nerve roots coming out through the neck, and as you can see, through the clavicle bone and down through the pec major muscle, pec minor muscle, and as you can see again, forget the joint capsule and the synovium, but there are the brachial nerves as they come down. So in this particular circumstance, we want to lift T1, we want to lift T1, that first thoracic segment, off of the shoulder girdle and off of T2 to free up that exact nerve root that we felt was involved in the pain of the left shoulder and the upper neck. And then this right here is also her left shoulder getting adjusted. Now, this is a more advanced shoulder adjustment rather than the one where people may put their hands on the hip. And you just want to warn the patient, especially a female patient, where your hand's going to be, and that you're like, you know, the knife edge position of my hand is deep inside the pec, very much on the glenohumeral joint, pushing in a downward motion. And what we're trying to do there is not so much set the shoulder, but what I want to do is have my hand, my right hand in this case, propped up underneath the shoulder blade so I can actually get depth of not just the glenohumeral joint moving back, but actually the scapula gliding behind the palm of my right hand as the whole shoulder girdle sets back. Of course, we want the patient's head to be neutral or turned away in this case, and we want that shoulder to go back in retraction so it's not so protracted out forward, putting tension and lengthening of the brachial plexus and muscles behind the upper back and neck. So if that makes sense, that's what I want you to envision. Now, and the last thing I will say in closing, the last thing for this video that's important to take home is that when I work with my patients all the time, it's going to be, you know, adjustments that, you know, hopefully made the biggest amount of difference. So they're not going to be these, you know, small adjustments that aren't, you know, that have no stay put power or holding, as we would say in chiropractic. My goal isn't to see them on this great amount of frequency, but if we have to, of course we will. So the thing is, we want to look for the most appropriate combinations and patterns. We want to look for what patterns work well in terms of their subluxations and compensations and how best to adjust them, and combinations. And in this particular case, adjusting the upper thoracic, staying in the shoulder girdle, working on the shoulder complex, for the reasons that I mentioned prior, is a great combination and pattern rather than just going, hey, let me adjust T1 on both sides, and or worse, imagine just not being able to adjust T1 there and having to do like C5 or C6 because that's all you could adjust. Maybe you didn't have the necessary skill or the confidence to get that T1 to move exactly the way you wanted it. And then of course, if you can't set the shoulder like that, working the muscles might have been the right thing to do on that particular day with some, not SOT, with a different kind of technique, or possibly even doing like an anterior to her first rib in this particular circumstance would have been a completely different adjustment than the shoulder complex adjustment. So these are just a lot of different examples, along with, here you go, the last one for us Gonstead people. It's if you want to think about it from a standpoint of, are you going to adjust the occiput to really influence the spinal accessory nerve? In this particular circumstance, that wasn't called for, but sometimes it just may well be. So I hope you got a lot out of this. Sorry if I stumbled or mumbled a little bit. I'm actually just doing this off the cuff. And guys, until next time, it's Dr. Pearlman.